Good morning, and welcome to the Healthcare Quality Strategies Interact Quality Improvement Program version 3.0 webinar. Your host, Dana Bungs, will now begin.
Good morning, and welcome to today's webinar, Interact Quality Improvement Program version 3.0. We're pleased that everyone was able to join us today. Healthcare Quality Strategies and the Healthcare Association of New Jersey are proud to support NJ Lane as part of the Advancing Excellence campaign. Today's speakers include Loretta Case, the Director of Quality Improvement and Clinical Services at the Healthcare Association of New Jersey, and Janet Noth, a Quality Improvement Specialist at HQSI. Both Loretta and Janet were participants at the first Interact Institute held at the Florida Atlantic University earlier this year. Today, they will be sharing best practices of the Interact program in an effort to support quality improvements and how to prevent unnecessary hospitalizations. Before we begin the webinar, I would like to review a few announcements and housekeeping items. First, we will have a question and answer session following the presentations. We encourage you to use the chat feature to submit a comment or question during the presentation. Please be sure to submit your chat to all participants. Your chat posting will be addressed and answered during the question and answer portion of the webinar after the presentation. Please note that your phone lines are muted. After the presentations, the operator will open the lines and you will be able to ask your questions using the phone as well. Finally, please stay on the line after the presentations. The operator will ask polling questions to obtain your feedback about the presentation. So please stay with us until the polling concludes. Next slide, please. I would like to alert you to the upcoming webinars in this series. Today's webinar will feature an overview of Interact and the communication tools. We also invite you to join us for the April 11th webinar on Advanced Care Planning Tools. And please stay tuned for the date on the webinar on Quality Improvement Tools. Next slide, please. Before we continue, we would like to get input from our audience with the polling question. Operator, could you please bring up the first polling question? The question is, are you currently tracking readmissions? Please select yes or no. You will have approximately 30 seconds to complete this, and we will share the results. Operator, if we could bring up the results, if they are in already, and we will be happy to share them with you. Excellent. So we can see that the vast majority, it looks like 47 folks out of 67, so that's 70% who are currently tracking readmissions. So that's wonderful news. And with that, I would like to turn it over to Loretta, who's going to briefly talk about readmissions and get us into the Interact program.
Good morning, everyone. I will start our discussion about readmissions and admissions to the hospital and how to reduce them using Interact by pointing out some discouraging, to say the least, statistics regarding New Jersey's rankings out of 53 states and territories. As you can see by the chart here, a 30-day readmission, meaning someone was admitted to the hospital and within 30 days went back to the hospital. In 2010, New Jersey ranked 50th out of 53. Including the territories. And in 2011, we still ranked 50th, even though we had a slight minimal improvement. Readmissions of patients discharged to home without home care. In 2010, we were ranked 48, and in 2011, we ranked 49. We actually increased that. Readmissions of patients discharged to SNFs, and this is very, very important. We ranked 53, rock bottom, in 2010. 26.87% of readmissions of patients discharged to the SNF went back to the hospital. And in 2011, that increased slightly with a minimal decrease in percentage. Readmissions of patients discharged with home care was somewhat better. We ranked 40th in 2010, 23.43%, and in 2011 we dropped, but mainly because there were other states improved at a more rapid rate than we did, and the percentage was 23.41%. This statistic is important because there is a significant difference in the residents who went home without any supervision and residents who received home health care. And then readmissions of hospice patients, we ranked 20th in 2010, and in 2011, we ranked 24. So much improvement is needed there. And I'd like to add for New Jersey statistics that we ranked 50th in the country with cost of health care to our Medicare recipients 2 years before they died. We ranked the highest in cost. And in the last 6 months of life, we sent the most people to the most specialists at the highest cost. So New Jersey has a lot of room for improvement. Today's objectives are we are going to discuss the Interact Quality Improvement Program and discuss how to use evidence-based data to implement processes to better detect changes in condition. Benefits of the Interact program, a live website tour. Janet will take us on a tour of everything that's available to you from Interact. Today we will discuss the communication tools, which are the foundation of the Interact program, and that's the Stop and Watch, the SBAR, and the nursing home capabilities list. And then we will allow some time, and we hope that you will share with us either your successes, your frustrations, or questions that you have about the program. Why now? Why is reducing the readmissions and hospitalizations overall so important, and how did this come about? Well, as you can see by New Jersey statistics, this is something that we have to take very seriously and we have to focus on and address. And what brought this all into focus was the Affordable Care Act, which was implemented in 2010 and now is rolling out in increments. And the aim of the Affordable Care Act was to improve care, improve health, and making care affordable. And making care affordable is a huge consideration. You all know of the current difficulties our nation is having with spending. The geriatric population in the United States is the highest, the most amount of people make up that population, more than pediatrics and young adults and middle-aged adults put together. And the consumers of health care, for the most part, are the older person because of chronic conditions and comorbid conditions and general health issues at that time of life. So they are the biggest drain on the health care money in our nation. The Affordable Care Act also puts a focus on two models of care. It kind of really changed the way we look at care and how we deliver care. And the two care models are acute care and chronic care, chronic conditions, care of chronic conditions. The emphasis is now on post-acute care. So the focus is on chronic care and a decreased focus on the reason that we're all here today is because hospital admissions and readmissions are costly, all too common, and mostly preventable. And one thing that I really want to point out as a nurse, as working with the geriatric population for a very long time, is that these are very, very important reasons, but the most important reason is that the quality of life of the older adults suffers immeasurably when they have hospitalization or frequent hospitalization because of a chronic condition. And I'm going to speak here about nursing home residents because the tools of interaction right at this moment refer to nursing home residents. But there are tools in development for assisted living and home care, which is really important because we have to learn to care for chronic conditions where the resident patient lives. So continuing with this, nursing home residents and all the other assisted living and home care may experience many complications from hospital visits. This includes any geriatric, any older adult. Confusion. We all know that when residents go to the hospital, just the general environment of the hospital causes an iatrogenic condition in the resident. We send them there to get well, but for some reason they get sicker. And this is a very important consideration because of several things that happen to a resident when they're admitted. Most likely they will have a Foley catheter put in because they're unable to get to the bathroom. And most likely they will be lying on a stretcher for evaluation, and tests that have to take place. It is statistics bear the fact that after 3 hours on a stretcher, pressure points are already beginning to show signs of appearing, especially in the ankles and the buttocks. Diverse drug events and polypharmacy. We know hospitalists now deliver care in the hospital, so they're doctors that are not familiar with the residents, and they have many additional types of medications ordered. Sometimes the medications that they're taking for their chronic conditions are not picked up and are not given. So many, I would say, adverse drug events probably are the number one reason why residents have to go back to the hospital. The healthcare-associated infections or hospital-acquired infections are of a huge concern, especially in light of the latest alerts that we're all receiving about the CRE or the carbapenem enterobacteria resistant organism, which has a very high degree of causing death in bloodstream, residents who are infected with it in their bloodstream. And most common way that this organism enters the body is through catheterization. So that is a very common occurrence in the hospital, and more potentially acquired by our residents, and therefore causing their mortality or death. I mentioned pressure ulcers and injuries and falls occur because they're in a strange place and unable to navigate it safely. It's strange kind of ironic that we are now talking about the hazards of hospitalization when just a few years ago hospitals were competing for every status and acclamation about how great they were. Magnet hospitals, JACO certified, best top 10 hospitals in the county and the nation. But the sad fact is, as an older adult, and probably stands true through every population, the more hospitalizations, the sooner you die. And this is a fact that we all have to take into account. Look at the picture. All too sadly, this occurs at the end of life. The hazards of hospitalization include decreased function. Residents who are able to perform ADL may lose one or two ADL functions by the time they get back to the community or their assisted living or the nursing home. Cognitive impairment is a big problem, especially with someone with Alzheimer's who has to have a hospitalization. You can count on them becoming more cognitively impaired and therefore decreasing their quality of life. The hospital-acquired infections, as we spoke about, are now really serious. They cause a loss of self-esteem. If anybody has taken care of an older adult who has C. diff and has that explosive, debilitating bouts of diarrhea, you witness right in front of you how deteriorated they become. And then resident and family satisfaction. Residents and families don't want to have their families in a place where they're constantly going out to the hospital. They want to be able to us to manage them more effectively in whatever level of care they're at, including home care. What is INTERACT? INTERACT stands for Interventions to Reduce Acute Care Transfers. It's a quality improvement process that targets 3 key strategies to help you reduce potentially avoidable hospitalization. The first one is preventing conditions from becoming worse, severe enough to warrant hospitalization. Managing selected acute conditions in the nursing home, the assisted living, and home. And the third, and very important, is improving advanced care planning for residents for whom a palliative care or comfort care plan is appropriate. INTERACT is not just a set of tools, it's a quality improvement program with different components. INTERACT improves the care of nursing home residents with acute changes in condition. The program will help safely and effectively manage nursing home residents without hospital transfers. And it supports communication of the patient condition to hospital providers when transfer is necessary. INTERACT is a process that was discovered or developed by Dr. Joseph Alexander at Florida University. Dr. Alexander has a passion for helping to improve quality of life of older residents. He's a geriatrician and has been for many years. He has worked with a talented team, likewise passionate nurses and social workers and other physicians to develop and pilot this program so that it is accepted by many geriatric associations, physicians associations, nurses associations throughout the nation. INTERACT tools consist of communication tools, which we will discuss today, which is the FBAR, the Stop and Watch, and Janet will discuss the nursing home capabilities list. And the quality improvement tools, which consist of tracking and root cause analysis of hospitalization, of why they occurred, how could they have been prevented, were they necessary. And there are absolutely instances where hospital transfer is necessary, and you cannot safely take care of the residents in your building. Advanced care planning tools, and as I say, I think this is probably 50% of the total program, and how we can address explaining and educating the reason that we want to keep you where you are and not send you to the hospital, to families and residents. It will always be that daughter at the bedside that makes an end run around staff, calls the doctor, says my mother has to go out, even though you know it's in her mom's best interest to receive care where she is. So that's a very important component. We will discuss this in greater detail on the April 11th webinar. And decision support tools. This is another important part of this total process. The decision support tools that Interact has implemented are, right now, they address gastrointestinal issues, fever, lower respiratory infection, dehydration, acute mental status change, which is probably the number one reason why we send people out, shortness of breath, change in behavior, and CHF, fever. I think that covers it for now. And these are neat tools that nurses can keep by the telephone on the nursing patient app, flip through so that they can make sure they can implement the care needs that they are going to and assess the resident accurately. A startling statistic, which I don't have a slide here for you, and it just came to my attention, but I will share it with you. The functional impairment is the key cost driver, not a chronic disease. Research found that 39% of elderly with one or more chronic conditions and functional impairment had at least one inpatient hospital stay, compared to 15% of elderly with one or more chronic conditions alone. So the decrease in function, ABL function, seems to be a driver of hospitalization for those with chronic diseases. And before I go into the benefits of Interact, I just want to discuss that the common causes of readmissions to the hospital and how Interact is going to help you work with these is the decline in clinical condition, a failure to recognize that decline, prevent for poor quality of care and not early intervention. Poor transition of care discharge planning. So many times, discharge from the hospital, discharge from some acute, the discharge plan is not complete or understood, or we're asking the resident to make appointments, get their medications, fill scripts, that we're not able to do. And so the information goes home with them, and that's where it stays. Lack of advance directive. We really have to consider making it clear what our choices are when we have a chronic condition, and we will discuss that a little bit today, but more thoroughly on April 11th. And the lack of the facilities, home care, or assisted living, lack of ability to meet the needs of the patient. In other words, it can be perceived or real. The resident needs higher level. Interact can help your facility safely reduce admissions and readmissions by preventing conditions from becoming severe, early assessment, and early action. In order to care for something, you have to identify it first and then take action. Managing conditions in the nursing home or other home care or assisted living without transfer when safe and feasible. We all have to develop ways that we can intervene in the acute condition when it is safe to keep the resident where they are. Improve advanced care planning and use of palliative care plans as an alternative. The benefits of Interact also include that the Affordable Care Act mandates that each facility have a quality assurance performance improvement program. The reduction of hospitalizations and readmissions fits that mandate beautifully. The regulation and surveyor guidance are currently being written. In other words, we're going to be surveyed and held to a standard in our processes on how we're going to reduce readmissions and hospitalizations. And improving how we address acute changes in condition and reducing unnecessary hospital transfers can be your potential goal of your quality assurance performance improvement program. And now we will have a live tour of the Interact website by Janet, who will take you through what's available on this website, how to navigate it, and how to use it. Good morning. Let's take a look at the website because we want you to feel comfortable with finding exactly what you need in a timely fashion. So here we are at the home page. It gives you an explanation of what Interact is all about, the purpose of Interact, and information about the publications related to Interact as you work with your staff and leadership in your facility. Here can be found from medical journals, the studies from Dr. Oslander's group, the pilot studies, as you can see. So this will help support you as you implement these quality improvement tools into your system. And then here with announcements, you'll see that here's the version 3.0 tools now available. And there's some further information here about the work they're doing for assisted living and home health tools. If anyone would like to click on there, they can get a little bit more information about participating in the formation of tools. Okay, I'm not going to click here, but you can also, click right under announcements to get to the tool part of the website. But I'm going to actually work across the red banner at the top of the page. So right now we're at the home page. And then the next item that you can click on gives you a little bit more detail about the Interact program. And there's a picture of Dr. Joe and his interdisciplinary team that has worked so hard to bring this program to you. So this is just another place that you can quickly glean some information. The next item on the red banner, this is the licensing agreement, which is new to the Interact 3.0 tool. But I'm going to come back to that because I need to show you the rest of the banner first. Next, they have provided you with educational resources. The implementation guide is a booklet that gives you strategies for putting this program into place, selecting champions, getting leadership buy-in, and it walks you through the use of the tools, which is very valuable. And then also, case studies are available here for you to use with your staff to move them forward and to validate the importance of using these tools and communicating with your staff and with hospitals and other facilities. So the first case study actually goes through a patient's journey that does involve a hospital transfer. And then the second case study shows you how, with the use of the Interact tools, the patient was able to be treated at their nursing facility. Next, across the red banner, we have the links to other resources and what the team has put together for you as we're all working so diligently to improve the transitions of care is best practices throughout the country that have been put together for you for your further review and for your easy access as you move forward with improving care of the patient. So on the right side of the screen, they also provide advanced care planning resources, which we will go into more detail at the April webinar, but you're certainly free to look at it for yourself at any time. And then next across the red banner, we have the project team. Just gives you a little more detail about who they are, where they're from. They're from all over the country, all different kinds of disciplines. And then lastly, we have the contact us. And this is a direct contact email to Dr. Joseph Oslander or Lori. Will certainly respond to you quickly. I know this because I have emailed them. So just know that Loretta and I are right here in New Jersey for you, and our contact information is also on the slide. So now that we've gone through the entire red banner, I'm going to take you back to the licensing agreement. This is new because the team wanted to bring attention to the fact that these tools are not to be changed or modified in any way. They have created these tools after much hard work and much research of best practices. So if you choose to utilize these tools, they ask that you don't change one word on it because then it's really no longer the tool they created. They also want to make you aware of the scope of use of the tool, and they want to make it very clear that they don't want you to embed this into your electronic health record at this time. You can actually complete the tool and then PDF it and put it into your system, but they don't want any manipulation of the tools at this time because they're working with point-click care to bring you an electronic system. So please read through all of this agreement information, and then since I already have, I'm going to click on I agree to get me to the actual tools that you can see on the right side of the slide. We have the 3.0 tools for nursing home, and then assisted living and home health is coming soon. To the right side of the page, you'll see the authorized printed Interact materials. And I'm going to go into a little bit more detail about this because I want to be able to explain to you the different formats that you can actually order the tools in. So right now I'm going to click in the 3.0 tools, and you're going to see the overview of the Quality Improvement Program. The very first item is the version 3.0 tool table. And this is going to explain how they want you to, or how they recommend that you order their material in these formats. So I'm going to go directly to the second page because that's for communication within the nursing home. Okay, since we're talking about Stop and Watch program, you'll see there's a column for tools, column for use, and a column for suggested format. So the Stop and Watch early warning tool is for use by CNAs and other direct care staff. And that suggested format is 4 inches by 6 inch laminated cards. The aide can write on the card and as the nurse, give it to the nurse. And then when that communication is complete, it can be wiped clean and used again. The other suggested format is 4 by 6 pads with NCR copies, and that means that the original of the Stop and Watch information would go from the CNA to the nurse, and then a copy would be available for the aide to retain for further conversation with the nurse. Second on this chart is the FSTAR communication tool. And as I said, I'm specifically speaking to these because this is what we're talking about today. And that's recommended for all the licensed nursing staff. And the format is 8.5 by 11 pads with a hole punch for insertion directly into your medical record. Because this is also a progress note, and there's really no reason for duplication. And then here we're also going to speak about the nursing home capabilities list, which is under communication between the nursing home and the hospital. And this nursing home capabilities list is for all nursing home licensed staff as well as the ER staff. And that's also 8.5 by 11 pads on a little heavier stock because that's going to be doing a little bit more traveling as you include it in various places. So I just wanted to make that clear to you, the different recommendations on how to order it. And now I want to just go back while we're on the concept of ordering the material and just take you quickly to the Medline site. So this is where you would click. And I just want to explain this a little more completely, that the Florida Atlantic University has made these materials available in specified format, both through working with these printers, these printing companies, and they can be ordered at fair market value at this link right here. And then there's no compensation either to Interact or to the Florida Atlantic University. They just did this for the convenience of providers. So right now I'm going to click on this link. It's going to bring you to the Medline site. It's going to bring you to the Medline site. And it brings us to the Medline site. So here we are, and up here you see the welcome, and this is where you would register as a new user, or you would log in if you've previously ordered. They've nicely put Interact as the first item that you can get to order. And as you just scroll down, you'll see very much set up like the tool website, quality improvement tools. And I'm just, again, going to scroll down communication within the nursing home. You can order the stop and watch tool. You can order it as a booklet. And you can order the stop and watch tool in Spanish. Okay, and then a little further down, here's S-bar, so that you get the main idea. And then you would click on whatever you'd like to order. It would bring you to another screen, tell you the cost, and depending upon the number that you order, the cost may decrease. So I just wanted you to be familiar with visiting this site, and they give you the information very readily. So it's very user-friendly, and Medline did a very good job here. Okay, so now we're going to go back to the tools. Okay, here's the overview. Remember, we started back here. We went to the tool table to find the format. And then this just gives you a little bit more information about implementation. Here's the quality improvement tool, hospital tracking rate, and these are Excel sheets, which we're going to go into more detail at a later webinar, and also access to root cause analysis information. So we're going to scroll down here to the communication tool, because that's what we're talking about today. And this is the subtitle of communication within the nursing home. And here's your stop and watch tool, which you all had the option to download for this webinar. And this is what you should hopefully have in front of you, so that when Loretta speaks to it, that this is what it looks like. Okay, and this is where you find it. And then the other tool that Loretta is going to speak to is the SBAR communication form and progress note. And just want to give you a heads up to what it's going to look like, so that you have it in front of you when Loretta's ready to speak to it. And then here we have the communication between the nursing home and the hospital. And the second one would be the nursing home capabilities list. And this was also available for your download. Okay, so those three tools you should already have in front of you. And then as we scroll down, we see the decision support tools, the care paths that are so vital for communication and consistency within a healthcare system. And just a very good resource. If you already have care paths within your system, it would be a good idea to also look at these best practices compiled by an interdisciplinary team, just to make sure that you have everything that you need in place. And then lastly, on the tools page, we have the advanced care planning tool. They provide a tracking tool, a communication guide, and they've really expanded this because of the importance on the end-of-life care and how we really want to empower providers to have that conversation and to be able to really give the patient and families the information that they need to feel confident in their care choices. So just going back up, I'm going to close my part here with the tour, and we're going to move on to Dinah with the next polling question.
Thank you, Janet. That was a wonderful tour of the Interact website, and I hope that everyone will take the time to visit the site and further explore the Interact program. Now, if you could proceed on to the polling question, that'd be wonderful. And operator, if I could ask you to bring up the polling question, the second polling question. The question is, do you use Interact? Please select yes or no and click the submit button. You will have approximately 30 seconds to complete the poll, and we will share the results with you as soon as we have completed the polling here. If I could ask the operator to please bring up the results to the polling questions here, and we will see how many of our participants are currently using Interact. It's always exciting. It's kind of like the Oscars. Could I have the envelope, please? And here they are. It looks like we have about 55% of the participants saying that they are currently not using Interact. So we certainly are very thrilled to have this opportunity to share with everybody what Interact is, and hopefully we'll have more people starting to implement it. So this is a wonderful opportunity. And with that, I will turn it back over to Loretta, who's going to start explaining some of these communication tools.
The first tool that I will discuss, because it's probably the most important in contributing to early identification, is the Stop and Watch Early Warning Tool. This tool is designed for staff such as any staff, anybody actually, but most frequently for the CNA, the bedside caregiver, the housekeeper, the maintenance department, and the dietary department. Many times the servers in your dining room will detect a change in residents' appetite, will see that they're not eating for 2 or 3 days, and that could herald a great many problems with dehydration and weight loss, and it's best to know that early on so that we can discover why they're not eating. But another important member of your team is the family member. When somebody is admitted to your facility with a chronic diagnosis, this is absolutely invaluable when you're admitting the resident and speaking with the family member about their expectations, the resident's expectations, and what care model will be used to take care of the resident. This should be also discussed. You really engage the family member when you say, you know your mom, Dad, I'm going to give you this paper that will give you the ability to communicate to us, the nursing staff, when you notice something different, when you notice that mom may have more difficulty breathing when she goes to the bathroom, or when her ankles are getting a little puffy, or she may tell you when you visit what is going on. And if you can't find a nurse directly to speak with, the nurse should inform the family member what this communication, the purpose of the communication, and where she should leave it so that the nurse is sure to see it. And very important part of that is even if the report was not significant, a call back to that family member to let them know you got the paper and you are definitely watching, observing mom or dad, and you'll let her know if there's anything going on or if there's any care interventions needed. This builds trust with the family, and I can't say this enough. Family trust in your ability to take care of their loved ones is paramount. It reduces all sorts of problems, most importantly, litigation. If a family trusts you and you communicate with them with good news, they're more ready to believe you and accept when you have to communicate with the bad news. This gives you a very good means to doing that. So you want to acknowledge that you got it and what the issues are and what you're going to do about it. I know it takes a little bit of time, but you only have to do that once or twice before the family gains trust. The most important thing in rolling this out, I have been to several nursing homes now to help them implement the Interact program. And when I speak to the aides, I speak to the aides by myself. I ask no other staff be there. Because I really want to get a sense of the culture and philosophy of the nursing home to see how accepted do these aides feel their communication to the nurses are. Because some nurses and other staff members have a bias that they don't even know exists. I have to tell you, probably the most important person in your building is that direct caregiver. at Dr. Alexander's training, the aides were referred to as the canary in the mine. If something's going to happen, they're going to be the first ones to know it. And that is why it is so important for nurses to have an accepting attitude, to be very proactive in receiving information from the aides. You have aides who are gifted, who are passionate about what they do. Keep in mind they can work anywhere else for the amount of money they make, but they choose to be here. So respect them for that and listen to them. And when I spoke to the aides about how they felt they were accepted, they really were very open in sharing that they knew who they could go to, meaning that some nurses blew them off, did not listen to them, told them it wasn't their patient, and find out who has that patient. There were other nurses who stopped what they were doing, listened to what the aide had to say, and whether they could respond right then or back or at a later time, they let the aide know what they found. So they reinforced the feeling that I made a contribution, what I said was accepted as important, and you know that we all need that feedback in order for us to function. So I'm telling you right now that the first thing in using this form that you have to really appraise how your nursing staff accepts information from other staff members, and most importantly, the direct staff member. The second thing that I was a little surprised about, but they were very happy about, was I had samples of this stopwatch in the pad with the copy. So the top sheet of the paper was white, like you see, and a copy was on a yellow piece of paper. So I explained to them something you fill out, you circle, just circle the letter or check it off, whatever way you want to communicate. And you put the name of the resident you're speaking about, your name, what the aide's name is, who you reported this to, and you put the date and time is very important. They were very happy to know that they could keep the yellow paper, that the yellow paper validated that they did report this. So, unfortunately, as some of them had experience with, the nurse couldn't say, you never told me. They had that paper that showed, yes, I did, and this is what I said. So it empowered them. I thought I would have more resistance, giving them yet another responsibility, but it was openly accepted and very happily so, because they had this paper to validate the fact that they did tell the nurse. I was very happy to hear that there are many nurses who they felt very comfortable about talking to and knew that they would be heard. So, again, another important piece of this is that you find that aide and you tell them, because you told me about Mrs. Smith's pain. She really had to go to the hospital because she had a surgical condition. Validate that aide is a part of the team, a very important part of the team, and she helped take care of a resident in an acute situation. They're the first ones that see the swollen ankle, or the difficulty breathing, or the loss of ADL, where they could wash themselves at the sink. They are no longer able to do that without great distress. So what they have to say is important. This stop and watch tool also contributes to the nurses gathering of data when she has to write a progress note or information for the MDS as far as ADLs go and the mental status of the resident. So this is an important contribution. It is not recommended that you keep this on the chart. You keep this in a place where your staff knows these filled out sheets are kept. Have a system in place that these reports can be turned into you at a pre-designated place. So if there are no nurses at the nurses station, that there is some place an aide can leave it and know that it's going to be attended to. But you must validate that you did it by telling the aide, I checked on her or him. Another important piece, as I said, is gathering the information that they tell you so that you can track decline over time or increasing severity of a condition. This early recognition is very, very important. Continuing with the second communication tool that we will be talking about is the SBAR. The SBAR was not a health form in its inception. It was originally intended for the Navy to communicate a serious event. If a ship were under attack, the commander or person in charge of that ship had to know what action to take, and he would be dealing with emotional, anxious people, giving him information that he had to make sense of, he or she had to make sense of in order to come to the right decision, whether to attack, whatever the option they had. From that situation, the SBAR, which stands for a summary of what's happening, what's going on here now, what happened in the past that maybe contributes to the current situation. So we have situation, background, and assessment. Assessment of what am I seeing at this moment, and how does it affect, in our case, the resident patient. And the recommendation or request. What am I asking you for? In doing this, and I know Janet has some more stories about this, but in speaking to physicians about how nurses communicate to them in an emergency situation, the one thing they said that bothers them the most, besides being unprepared, is the emotion. The nurse is now anxious, is now upset that this is happening, and she needs information, she needs help, she needs support to do the right thing and to give the resident the right care. So because of the emotion that enters into it, she or he is not prepared in an orderly fashion to tell the physician or the advanced practice nurse practitioner, or physician's assistant what is going on. Especially in those instances on the weekend, Saturday morning, 3 a.m., who you know you're speaking to the covering doctor, who has not a clue what this resident is all about, and is depending on you to give him the information that he needs to make a decision. Hospitals are being penalized according to their hospitalization rate. Physicians are being incentivized to keep residents out of the hospital, to treat them where they live, so that this physician wants to work with you and wants to be able to take care of the resident where they are, but he needs the information. Nobody's going to take a risk of keeping somebody in your building if they're not sure what the problem is. So if you're looking at the first page of your communication form, it clearly states what steps you should take before notifying the provider. Evaluate the resident. Complete relevant aspects of the SBAR form below. Check the vital signs. And this is everything you have in front of you before you make the call. The blood pressure, the pulse or capable heart rate, temperature, respiratory rate, oximetry, and finger stick for glucose if the resident is a diabetic or if it's indicated. Review the record. Well, this is what I'm seeing. Let me see if they had it last night or the day before. What did the physician say in their last progress note? Now, I know this sounds like this could be tedious and could take a long time. Nurses that have been using this for over a year assure me that a competent, skilled nurse can do this in under 3 minutes. And I want to point out right now that this is not a duplication of documentation, that this is your progress note. This is a copy that you're going to send to the hospital so that they know and have as much information as the doctor had and as much information as you had at your disposal. Review an Interact Care Plan or acute change in condition file card. Those are the cards I spoke to you about that deal with several chronic conditions that give you, and acute conditions that give you some idea what to do so that you can ask for an order or make a recommendation. Have relevant information available reporting, such as a DNR and any other end-of-life or advanced care planning. What is the baseline, vital signs? So good to give that information if the provider doesn't know what's baseline on this resident and how is this different, what you're telling me. Allergies, medication issues, etc. So having that in front of you and able to report you quickly for fill out the form. And very important, the change in conditions, symptoms, or signs I am calling about, and list them. Shortness of breath, declining function, change in mental status, whatever it is you're reporting, pain, acute pain. This started on what date this started, and since it started has gotten worse. Things that make it better, things that make it worse. This has occurred before, and here's what we've done at that time. The background is the other diagnosis. Is very important that the provider have a complete list of comorbid diseases that the resident may have. Was there a chest x-ray done just hours ago? Give them the report. Anything that you have that will speak to the issue at hand, the provider should know. Are they on a new medication? How important is this? Because it simply may be that the resident is having an adverse reaction and can't tolerate the medication, or maybe he's interacting with other medications he's on, or if they're on Coumadin and now they're bleeding. You know, this is all pertinent information. Going to the second page, which really is a quick down and dirty look with a check. Mental status changes. Is increased confusion, decreased consciousness, sleepy, lethargic, other signs and symptoms of delirium, disorganized thinking, hallucinations, delusions, any of that. New or worsening behavioral symptoms and unresponsiveness. Functional status changes. You've noticed and been reported to you by the caregiver that they need more assistance now. They're taking longer to take care of over time. They have decreased mobility, or they're walking with an unsteady gait. They're ataxic in their gait. Respiratory symptoms, abdomen, GU changes, any lab results that speak to the symptoms that, or any lab results, period, that were done recently, and that advanced care planning, DNR, DNI, DNH, so that doctors know that these orders are in place, and he's not going to tell you as a first resort to send them to the hospital. And then this is where the nurse's competency, skill, education, and training come in. And that's in the assessment piece. Because you're making an assessment of everything that you've collected, everything you've seen. You're implementing your critical thinking. What does this mean? What am I looking at here? How can I describe this? And this is when you put it all together and report to the provider. And the LPN, their standard of practice allows them to, the resident appears. They can evaluate. They can give you information about what is apparent to them. Then the request. What are you looking for? What is it that you want the doctor to order? And this is important in case your doctors or providers are not aware. What you can do right there in the nursing home to take care of this resident. I can start this IV. We can get this antibiotic in this amount of time, and we can keep the resident here. Or if signs of dehydration, we can hydrate him. I just need orders for IVs. Whatever it is that you're capable of doing. We could get this test in. We could do an EKG. And I'll get back to you with the results. At the bottom of the page, the name of the family, the healthcare proxy or agent notified, and report to the primary care clinician. This is very important because this is a regulation that you must notify these two parties, the date and the time you notified them, the staff name, and of course, most important, your resident's name. So this is the stop and watch and the SBAR and the nursing home capabilities that Janet is going to talk about is a way we have had success in rolling out this process. If you try to roll out the whole process at once, you may overwhelm your staff and overwhelm yourself. But you have to start somewhere. And it's to get everybody thinking. Start with the stop and watch. Choose a champion, a person that you know, an aide that you know is dedicated, is compassionate, is open to change, and is not going to look at this as another task or another responsibility, but make sure that that champion gets the reinforcement that he or she needs in using the form, and that will be contagious, that will spread. So another very good idea that I got in my travel was that this one nursing home collects the copies of the stop and watch, and every 2 weeks they pick one out. And that aide that initiated that form is asked to give the story. Tell how you came to notice this, what happened to the resident, and the part that you played in that. And then reward that aide with a gift card of some kind for gas or for food or for coffee, whatever isn't good for them. And the other aides will see how much importance you place on this early detection and reporting of residents' condition. The SBAR communication absolutely needs a talented nurse, a champion, a nurse who recognizes that this is the culture change that we are, that is evolving, that we are changing the way we deliver health care, that the focus is on chronic care and we have to take care of the residents, all the negative hazards of hospitalization, how we want to keep the resident from suffering that. That nurse on one unit on the 3 shifts should be asked to implement the communication form. And then again, you as the leader in your building can go and ask the doctor when Nancy reported to you about this condition, were you satisfied with the way she organized the report? And whatever, hopefully it's positive, feedback you get, give it to the nurse. Let her know Dr. Smith was very impressed with the way you gave your report. And with that, I'm going to hand it over to Janet, who will talk to you about another important communication tool, and that's the nursing home.
I just wanted to talk about the SBAR comment that I shared with Loretta earlier, and she thought it would be valuable to share it with you. I have been involved with meetings of physicians, and the point that was emphatically made was that the physicians do not want to receive an emotional call at midnight from a nurse with incomplete information about a patient is in crisis. And I know Loretta had already said that, but the doctor said they have no choice but to send the patient to the emergency department, especially through the covering doctor. And the physicians really spoke about this quite a while because they felt that they're being thrust into this impossible situation much too often, and their frustration really made an impression on me. And their conversation did lead to the use of SBAR, and the group felt that they really wanted to encourage nursing homes to use this form of communication. They want a complete patient report. They want it to be consistent every time that they have a call from that nursing home. And if your facility can do that with each nurse on every unit, on every shift, you're moving in the right direction, you're building the trust of the doctors, and everybody wins. And it would certainly bring confidence to the nurses that are giving reports to a doctor. They'll know that they've covered everything pertinent because the form prompts you by body system, and it guides the clinician to gather their thoughts in an orderly fashion so that they can follow care paths for recommendation. And if a transfer is required, the physician knows that an identical report goes to the ED and the transfer can be expedited. So in addition to the SBAR, the nursing homes have implemented the nursing home capabilities list, and they've already educated the physicians as far as their patient capabilities. So perhaps the patient can stay right where they are with updated orders, thanks to using best practices. So let's take a look at the nursing home capabilities list, which you should have in front of you. This is very easy to be filled out. As you can see, you put your facility name and address, and really the best phone number that you're actually going to get a clinician and who that clinician would be. Very important, because if you expect the emergency department to buy into this, they have to know that if they call, that they're going to get a person that's going to give them the answers that they're looking for. So on the left side of the capabilities list, we have the primary care.
And a nurse too.
That's the primary care.
I don't think so.
Hi, this is Dinah from HQSI. Can we make sure the phone lines are muted? We were getting a little bit of feedback there.
Okay.
Medicare has that.
All right, so do we have time?
Let's go ahead. Okay. Sorry about that, everybody.
Primary care physician clinician services are on the left side of the page, and then it goes on to diagnostic testing, which is very important to know, that these tests are going to be done in place if you can do it. Consultations, social and psychological services.
And please down to 001
Therapies on site. And then on the right side of the page, we have nursing services. They want to know, can you do INRs? Do you have the ability to do nebulizer treatment? And very important are the interventions. IV fluids, IV antibiotics are definitely being utilized in the nursing home. So they want to make sure that your staff has all of this capability. And then at the very bottom, very important, are the pharmacy services. So that's just a quick overview of what the form actually looks like. But I just want to go into a little more depth about how it can be utilized. So let's look at it from the nursing home perspective first. First, you'll need a champion. We can't be more emphatic about that. You need the support of leadership, and you need to have your medical director on board. And when this is completed, this form needs to be given to all physicians, nurse practitioners, and physician assistants that have patients or will be covering patients or residents in your facility. All clinical staff needs to be aware of this information and where it's going to be kept. Perhaps someone realizes, we really need to update this form because we have a little more skill or capability that we've been working on. So we want to make sure that it's kept up to date and that people are aware of what you can do. The staff needs to be qualified to perform the specialized services that are listed on this form. And you certainly want to support this tool by an in-service to make sure that your staff understands the responsibilities. And it's also very good to review with new employees as well. And, try to always validate your staff and the level of competency that they have achieved, because they're working hard to put a good face on your nursing home. And make sure to include your social workers, your discharge planners, case managers, because they're some of your best advocates. And consider sending a copy of this capabilities list with each and every transfer to the ED. It just can't be seen enough. And just know that every transfer should not be an admission. When you phone the emergency department with the warm handover to let them know your patient's coming, be their advocate. Advocate for your patient, for your staff, and especially if you expect the patient back to your facility after this episode is stabilized. Make it known that you are able to continue the care for the patient's condition in an environment where the patient or the resident is used to living with familiar faces around them. So I just spoke to you about that physician meeting that I was at, and I just want to let you know that in their community, 18 nursing homes have completed the capabilities list because no one wanted to be overlooked when it came time for discharge. So let's look at this form through the eyes of the emergency department, how to best implement it. Once again, you need a champion. You need someone to advocate for this information. The information needs to be shared with all shifts. You need to be able to answer their questions. What is it? Why is it? Where can we find it? Are you keeping the nursing home this information in a notebook? Is it on your employee intranet? Make it accessible so your staff will easily go to it, because we want to improve the patient care and we want to appropriately transfer the patient back to a safe environment if they are not admitted. And then a very big group that needs to absolutely be on board with this is the hospitalists, because they're the ones that are sending their patients back home after they're cared for. Once again, you'll need a champion from the hospitalist group, and always commitment from the leadership. If the capabilities list can be kept somewhere on the hospital computer system, this will provide easy access for all staff. Also, you'll only need to update it in one place. And if you transfer patients to 18 different nursing homes, all of their capabilities lists are visible to the ED staff, to the hospitalist, to case management, to everyone that's involved in patient discharge. So we also have to keep everyone involved in patient discharge informed. And we know that this information can expedite decision-making, safely return the patient back to their nursing home, or determine the best facility for their newly revised level of care. The communication between the hospital and the nursing home is essential for best patient experience possible. You are not the only nursing home that has access to the Interact Quality Improvement Program, and others will certainly highlight their capabilities to put their services upon discharge in the best possible light. Just remember that hospitals or nursing homes can start this conversation, and now is a very good time to start thinking about your implementation plan. So with that said, let's move on to where we can input the nursing home tools. The new resident admission, we're going to follow through the white boxes here right down the center. This is the journey of the patient. Here we get the patient into the facility for a readmission, and a reassessment is done. You see, you have your advanced care planning tools immediately. You want to know, have their thoughts on care for end-of-life treatment, has it changed? We always want to reconcile the medication. So the patient has been there for quite a while, and then the CNA realizes, this patient seems a little bit different to me today. So what are they going to do? They're going to fill out the stop and watch tool right here to the right, and they're going to let the nursing staff know something's not quite right. Let's take a better look at him. The nurse goes in and says, absolutely, I need to get a little bit more information, to get a little bit more of an evaluation on this patient. They do an SBAR form and a progress note, and they're all set to talk to the clinician for new orders or possible transfer. We move on down. It looks like the patient is going to have to be transferred. So we have all the tools on either side that you can use to improve care. And then at the very end, the key to the quality improvement program is to be able to look back at that transfer. What could you have done differently? Was the transfer appropriate? And most importantly, to share this and learn from your staff input to improve patient care continually. So now Loretta will go into a little bit more detail on implementation of the Interact tool.
All right. I'm going to go through this quickly because we have touched upon it during the presentation. The first thing that has to be is that leadership has to buy into this. So that means engaging your corporate, your administrator, the director of nursing. The director of nursing typically is the champion to roll out this program with help in her staff for the different aspects of it. MDS coordinator is important for tracking and gathering information. So there's many people that can take on a piece of it. But to get it implemented, that's the most important thing. You want to identify that one champion, one unit,
for a week, a month, to roll it out and then spread it to your other departments. If you are a subacute or long-term care, it's probably that you'll see the most action, as it were, in your subacute unit, so that might be a good place to start. Address your barriers. Identify what they are and find solutions to overcoming them. You are going to get pushback. There is going to be resistance. This is change. Give positive feedback. I can't stress that enough. To the family members, to the CNAs, to the physicians, to the nurses making the call and using the SBAR successfully. Promote peer-to-peer champions at all staff levels. Track, trend, and benchmark well-defined measures. Get in the habit of doing that. You have to do it already for requirements. So this is just a quality assurance program that you're going to do a root cause analysis on your hospitals to find out were they potentially avoidable or did that resident have to go. Look at the time. If you're on a Friday night and you get 17 admissions and somebody's having acute changes, is that when you're going out? Is it because your nurses are so involved in admitting people that they can't really watch the back door, as it were? So then you know you need to put on maybe some extra help for a period of time to help with those admissions so the nurses can pay attention to the residents there. Use the Interact website. As Janet pointed out, they are very helpful. You type in a question. I received one back in 3 hours. And it was a detailed explanation so that I understood it. Along with the Interact Use Medline. Medline has 13 modules for training, 4 of which are free. So acquaint yourself with them so that you have your in-service and instruction available and have a program to roll this out. The Interact e-curriculum, as I said, has the core overview modules free, 9 implementation training modules. There's a fee for CEUs. All of these are modest cost. This is not a huge financial undertaking. Implementing the whole Interact process is done at a very modest expense. And it reaps benefits. Benefits in quality for your residents and benefits in the facility because you keep your beds full because you are a provider of choice. Documentation of the goal of Interact is not to duplicate. Currently, you can and should keep your SBAR communication in your record as a completed progress note. Completed tools can be placed in the electronic health record in PDF format. Stop and watch or red flags that expedite evaluation by the DON, by the MDS coordinator, and helping your readmission audits what's going on here. Click care users. It's embedded. It will be able. Those users will be able to use this as part of their EHR. And I do want to state that the Interact is working with other communication companies to form Interact into their EHR. It's a work in progress, as it were. So I thank you very much for your time and attention today. It was our pleasure to present this to you, and I see that we have a few minutes for questions.
Thank you, Loretta. At this time, we will begin the question and answer portion of the webinar. We have time to take maybe 1 or 2 questions via the phone lines. If I could ask the operator to open up the lines, that would be wonderful. And while go ahead.
Ladies and gentlemen, if you'd like to ask a question, please press the number 1 key. Again, if you have questions at this time on the telephone, please press the number 1 key.
And while we wait for questions to come in via the phone, we will take some questions from Dan Moles, who has been using the chat box. The first question from Dan is there New Jersey versus other SNF readmission data available that factors in levels of acuity and length of prior hospital stay?
That's a very good question.
I believe that CMS has, if not already implemented, has plans to implement some data on hospitalizations and hospitalizations statewide, but I'm not sure it addresses the acuity level or the length of stay. That will be something that we will have.
So we absolutely will research that. Those are excellent questions to look at, and I think many people would be interested. Alicia, do we have any phone line questions?
Yes, we do. We have a question from Amy Stark at Whispering Knoll. Please go ahead.
I was wondering, is there an expected time when the forms for assisted living would be ready?
Yes, they are now being piloted. The Interact group is with the Assisted Living Nurses Association to implement a strategy for assisted living. And I will tell you, they're not that big of a change. For those of you in assisted living, I would absolutely use the SBAR communication form at a minimum, the first page and the last page, because I know you don't have some laboratory data and other information that the nursing home form asks for. But this is really a wonderful tool for assisted living to use. The stop and watch you can implement tomorrow. It's even more critical in assisted living that the aides report to you what the changes in the resident are, because sometimes you don't see them for days. So that's a critical facet of this.
And also on the home page of Interact 2, you'll see right below announcements, there is a part, you just click on the assisted living link, and then it brings you to an application where you can submit your information and be part of the pilot, possibly be selected to be part of the pilot. So that's another opportunity for you to be involved in the new tools.
Okay, thank you.
I just have one more comment. If you're interested in rolling this out, if you go to ncal.org, they do have an assisted living SBAR that they designed waiting for Interact to implement theirs. So you could use that in the meantime as a guide.
Okay, thank you very much.
You're welcome.
I'll take another question here from the chat box. It's again from Dan Moles. The question is, in a resident-centered culture of care, how can a SNF prevent readmissions if that is what the resident or family wants?
That's another good question. And actually, if we are in a person-centered care, then that's what will happen. That resident will go back to the hospital. I don't believe any provider would deny that to a family member. So at this point in time, that's probably a good reason why the resident would go back.
Right, and the more education that we can provide the family and the patient about the trajectory of the chronic disease, we might be able to get people to understand that sometimes the comfort level is exactly staying where you are, but every case is unique, and it is absolutely up to the patient.
Thank you for those. At this point, I'd like to ask for one more phone line question. Do we have another question, Alicia?
Yes, ma'am. It's from Sharon Sipple at Atlantic Health. Please go ahead.
Hi. This is Sharon Sipple. And first of all, I'd like to applaud this process and program. It's amazing, incredible, and I'm smiling from ear to ear.
Good.
Second, when I'm looking at slide 23 and I'm looking at the flow chart for the journey of the patient care, it actually ties into the last call. I see an opportunity where the RN or LPN is doing an evaluation and notifying the physician or PA, but it may be a good time to notify the family of a change. Because I feel when they come to the emergency room in acute care, that's sometimes when the family is arriving and finding out what's going on, and often they don't want acute care. And the patient's already here.
That's exactly right. Using the form, though, it directs you to notify the family. And in the case that a family doesn't want the resident to go to the hospital, and that's what the resident desires, then actually we really should have that conversation before that emergency occurs. And when it asks you to let the provider know, that's a question for them. But sometimes then the doctor will speak to the family member and the resident if it is a critical situation. I think everybody's thinking on this is going to turn around now. As providers, we always thought we had to send to the hospital, because we know best. But now if that's not the case and the resident has a choice, then we're going to honor that choice. But everything has to be set up so that we could do that successfully. Can't wait till something happens and then try to manage it.
Right, even if the management is that they would rather not have care.
That's right, and that's where the post is going to really help us. We will, as I said, we'll go into that in detail on April 11th, but that is a form everybody should be aware of and everybody should be using now. Thank you.
Thank you.
I see we're getting lots of questions and even some back and forth in the chat box, so that's wonderful. But we are starting to come to the bottom of the hour, so we're going to capture the chat questions we have coming through, and we will address those after the webinar and share the responses back with participants. So I would like to ask Alicia now to open up the final polling questions. We do ask for your participation in those.
The first question on today's evaluation is, after participating in this webinar, I am able to describe the key tools in the Interact Quality Improvement Program. Please press 1 for yes or 2 for no. Again, after participating in this webinar, I am able to describe the key tools of Interact Quality Improvement Program. Please press 1 for yes and 2 for no. And one moment while the results come in. Okay, polling is now closed for this question. One moment while we prepare the next question. Okay. Our next evaluation question is, after participating in this webinar, I am able to identify the benefits of the Interact Quality Improvement Program. Please press 1 for yes and 2 for no. Again, after participating in this webinar, I am able to identify the benefits of the Interact Quality Improvement Program. Please press 1 for yes and 2 for no. And polling is now closed for this question. One moment for the next question. Our next polling question is, my knowledge of this information increased based on the presentation. Please press 1 for yes and 2 for no. Again, my knowledge of this information increased based on this presentation. Please press 1 for yes and 2 for no. Polling is closed for this question. Hold while we prepare the next question. Our next question is, I plan to share the key tools of this intervention with others at my organization. Please press 1 for yes and 2 for no. Again, I plan to share the key tools of this intervention with others in my organization. Please press 1 for yes and 2 for no. The polling has closed for this question. Please hold while I prepare the final question. Ladies and gentlemen, the following question reads, overall, I was satisfied with the session. Please press 1 for yes and 2 for no. Again, overall, I was satisfied with the session. Thank you, ladies and gentlemen. I say the results, and this question is now closed. Dinah, you may continue.
Thank you, Alicia. With that, I do want to thank all of our speakers and participants for joining us today. And as a note, this webinar has been recorded and it will be made available on the HQSI website along with the materials. Thank you for attending, and that concludes our webinar.